Hello, everyone. I'd like to welcome you to today's activity entitled Making the Clinical Assessment of Generalized Pustular Psoriasis. My name is Stephanie Simmerman. I am a dermatology nurse practitioner at River Chase Dermatology and Cosmetic Surgery in Naples, Florida. I will be joined later in this activity by my colleague, Christine Kucera. Christine is a dermatology physician's assistant at Bayer Dermatology in Dallas, Texas. I would like to thank Behringer Ingelheim for providing an unrestricted educational grant to help support this education. And now let's get started. So when we talk about psoriasis, a lot of us will lump it in terms of just we use it as a bucket term. Many people don't spend the time to kind of differentiate the different types of psoriasis. Because as we know, we have guttate psoriasis, inverse psoriasis, pustular, psoriatic, and erythrodermic. And so we also then know that we have some subtypes of psoriasis. So there's a little bit of this danger of if we just use psoriasis broadly and we don't, really pay attention to the different types and subtypes, sometimes we get this kind of umbrella term. And what we're seeing happen in medicine right now is this kind of innovation, right? And for many of the inflammatory disease states that we treat. And so our immunotherapy is becoming very selective and refined. And if we use these bucket terms and we don't really get a little bit more detail oriented, it can fail to acknowledge that underlying immunology and genetic factors that make one type of psoriasis different than another, without people just starting to think, well, all psoriasis should be treated or could be treated with the same type of biologic agents. So when we look at generalized pustular psoriasis or GPP and the demographics, what we're looking at is saying who is most frequently impacted. We know it's around the fourth decade of life. It affects all races. We know that females tend to be impacted more than men. And over or nearly 65% of patients with acute GPP have a history of plaque psoriasis. So, and this can happen years before. So these are just some of the pearls of knowing when I walk into that room and somebody starts checking these boxes, what and how that impacts what I'm thinking for my diagnosis and my differential diagnosis. So the morbidity and mortality associated with GPP can be pretty severe. It is a severe form of psoriasis. This can be the first and only psoriatic manifestation for this person, or it could be after an onset of plaque psoriasis. So it's an important part to note in our history and to assess, and we're going to jump into a little bit more of that later in this discussion. This is something that if left untreated or misdiagnosed, it can result in some pretty significant health conditions for a patient. I mean, you're looking at the potential for organ failure, increased risk of infection or sepsis, and this can even result in death if missed and the person is very sick. So when we look at the subtypes, really what you're looking here, and I don't want you to get too hung up in too many details, I want you to get the overall picture, is you're looking at, do we have a systemic patient here or do we have a localized skin patient? And so what you're really looking at is the generalized pustular eruptions accompanied with systemic symptoms, things like fevers, arthralgias. These are the patients that we have to be really concerned with. These are the patients that we are not going to just treat in office because these patients, this can be a life-threatening condition. Then we have our more mild patients that have no systemic signs and symptoms, and the lesions typically will resolve within a few days. So it's really looking at it and saying, is this somebody I'm going to need a little assistance with, or is this someone that I think I can manage here just in the derm office? So the most common symptoms with GPP, most often you're going to see recurrent, you're going to see widespread sterile pustules, the lakes of pus as we like to call it. You're going to see the desquamation and erythema. It could be relapsing, it could be persistent in nature. There's a lot of variability in which these patients can present and the frequency and severity of their flares. And remember, these patients can present with or without systemic symptoms of pain, which we see fever, chills, malaise, and joint inflammation. So there's an organization, ERASPIN is the acronym that they use, and it's the European Rare and Severe Psoriasis Expert Network. And what this group did is they came out with a consensus statement on the phenotypes of pustular psoriasis. And what we see here is them basically saying, okay, here's our definition of what pustular psoriasis is, primarily sterile, right? Visible pustules on the non-acral skin. And then they look at it with these subclassifiers, with or without systemic inflammation, with or without psoriasis vulgaris, and relapsing, right? Greater than 1 episode or persistent for over 3 months. So the symptoms of the GPP flares that we spoke about earlier, what we see is going left to right on the chart here are the most frequently seen. And we see that pain and psoriasis are pretty high up there. You've got rash and fever. None of these are too surprising, but it's really assessing when we're asking those right questions of really trying to figure out which way this patient is going and how severe. It's knowing the right questions to ask our patients. And so I thought this was an excellent chart to be able to say, I'm going to add this to my, maybe my electronic health record to make sure that I remember to ask a person about all of these different symptoms that they might be experiencing with their flares. When we look at the clinical assessment, a detailed history, right? These are rash patients. Some are straightforward and some are more involved. And this particular case is going to be a little bit more involved. It's going to be really taking the time to sit down, pause, and potentially let the rest of your clinic know you might be running a little bit late from this more complicated patient. So you're going to want to get a detailed history. Part of the questions we're going to ask, is there a history of plaque psoriasis? Is there a personal or family history of plaque or pustular disease? Are they having those systemic signs and symptoms? You can't drill it in enough about how important it is to pick up on these things because they're going to change your intervention and they can really make a huge impact on someone's life, making sure that we do a great job of screening for the more severe and potentially dangerous cases. A review of a recent and current medications. We know that this disease state can be impacted by medications. Stopping things like systemic glucocorticoids too quickly, certain biologic medications. And we've got a pretty good list later on in this presentation about other things that can impact a flare and cause a flare. And doing an overall thorough skin exam. We tend to be able to assess things pretty quickly in dermatology, but sometimes making sure that we do a really good check, get these patients in gowns and look them over from head to toe is very important. So when we talk about the diagnostic tools, this is something that's so important. And Leanne and I spoke about it in her case study of, making sure that what you have in office you use. You will never regret running a test. It's the one you don't order, right? That sometimes can make an impact. Sometimes you have to call back a patient to do it if you feel like you need it. And sometimes these things help you rule out other conditions pretty quickly because as we all know, these tests that we order trickle in at different times while we're waiting for path reports, while we're waiting for lab work. And so using an in-office skin culture can be very effective to help make sure, right, that this is just sterile pus and there's no bacteria. When we look at the serum markers, looking for this, when the systemic symptoms prevail, you're looking at a CBC, CMP, and, a SED rate or CRP for inflammation. Doing a skin biopsy. This is something that you're going to want to do a punch biopsy on. Some people, when you read the literature, will talk about doing a DIF. And the reason that they'll talk about this is sometimes if you're not confident in your clinical, diagnosis and you want to ensure you're not overlooking something else, this helps give you some additional information to be able to treat this patient with greater confidence. So we want to do a punch biopsy on these patients. It's going to assist us with ruling out things like drug eruptions and infections and immunobolus diseases. And being aware that sometimes you can have up to a 5 to 10 day process delay. I know, sometimes in our practice, it depends on a patient's insurance, where their, pathology, their specimen is sent. And sometimes that can delay a read for us. Otherwise, we have a pretty good turnaround time, but it's just being aware and cognizant of how all of those things can impact patient care. Blood cultures are also something that if you were really worried about a patient, that could be in the discussion if this is a patient that's going to the hospital. Knowing the mimics and triggers is really important. You want to know what to look for, what to rule out, and how you're going to test to make sure that you can do that appropriately. And so knowing that we're going to look and see, is there a potential for infection and how are we going to test for that, right? Could this be related to AGEP, where we're going to be ruling out and more concerned with medications impacting? Could this be a drug reaction, right? Look at all of these different medications, whether it's antibiotics, calcium channel blockers, NSAIDs, antifungals, what meds can impact conditions like this? and then other neutrophilic or pustular conditions, a pemphigus, right? A subcorneal pustular dermatosis. So these are things where I've got personally, I have a digital notebook. And so whenever I'm at a conference or doing educational things like this, I'll go and I'll update my list, and I will have, some of these things on there so that I'm not having to, in the middle of clinic, open up the textbook. I've got my own little personal, if you will, dermatology Bible that helps me just quickly look, assess, and know what I'm going to put on that pathology requisition. And also what types of medications can be responsible for this. A big one that we'll see, or, I've seen multiple times, are the TNF inhibitors, but your NSAIDs again, your methotrexate, your corticosteroids, and then also knowing pregnancy status. Have they had any recent infections? And then stress levels. We've all seen how significant stress can be on these chronic inflammatory disease state conditions. The role of the care team. So we're looking at the outpatient versus inpatient, and it really goes back to what we've kind of been drilling in, as we've been going along these slides. Your clinical assessment and your diagnostic tests are really going to help you determine and what that patient looks like when they're walking in the door. We can pick up in dermatology pretty quickly those that we're really concerned with and those that appear to be more of a basic, easier patient to manage, in a primary care, in a dermatology clinic, if you will. Something that I have done and that I found to be very successful over the years is that if I am sending a patient to the emergency room because I'm worried about something and I think it's something that maybe they may not be that well versed on, I will send them with printed out literature, say from a DermNet NZ, about what I'm thinking is going on with this patient. I will also write my cell phone number on the top of it. And I will write any medications that I think might be pertinent on this, in case this is something that's new and maybe they're not dermatology, potentially trained in the ER. Anything that I feel like is really going to help that patient get the care that I suspect that they need. And sometimes I'll even phone over to the ER before I send them, just to let them know and give them a heads up, so they might be able to do some reading for, a few minutes, making the assumption that maybe they're not as familiar with this, and that if they are, fabulous, but if they're not, I've just really helped them kind of hone in on it and get some answers faster for this patient. So in summary, due to the heterogeneity of this condition, it can be difficult to identify. It's rare, we don't see it frequently, but when we see it, having and doing these educational sessions really helps you become a stronger clinician, to where that differential diagnosis just comes to you so quickly, because in the management of the condition, because you know what you're looking for and what you're trying to rule out. And so we should suspect GPP in any patient with a sudden onset of erythema and pustulosis. We've got a variety of diagnostic tools at our fingertips, including those cultures and biopsies and lab tests. And it's critically to diagnose these patients with GPP because of the potential severity for life-threatening conditions that can occur if this condition is mismanaged. We'll now move into the second part of this activity, where we'll be discussing a clinical case study focused on the management of pustular psoriasis. I'd like to bring in my colleague, Christine Cusera, to help me with this segment. Hello, Christine.
Hi.
Thank you so much for joining me today. I really appreciate it. All right, so we're going to be discussing a case of mine that I found to be a little bit challenging. It was not a black and white kind of textbook case where I knew exactly what I was going to do and how I was going to manage it. And so I'm really interested to hear if you have any additional thoughts or considerations as we navigate through. So I appreciate this.
Absolutely.
All right, so let's discuss our patient here. We have a 46-year-old white female with widespread pustules and erythema, especially notable on her hands and feet. She was referred to our clinic from another general dermatology provider. She had mild skin pain limited to select areas of her body. No fever, no chills or joint involvement, so we didn't have the systemic signs and symptoms to be concerned with. And then we had significant mobility limitations due to pain in her hands and her feet. So her patient history: she had no family history of psoriasis. Her medical history was positive for anxiety, severe uveitis, and the spondyloarthropathy. Her current medications were adalimumab at 40 milligrams weekly and a pretty good dose of alprazolam with 3 milligrams daily. For her psoriasis, she had tried and failed tapinarof, calcipotriene, and betamethasone. She had failed also oral prednisone and roflumilast. Her physical exam and diagnostics. When I walked into the room, she was wearing sunglasses because she was so photosensitive from the uveitis. She had mild GPP and severe palmar-plantar pustulosis present. Quite intense pain upon palpation of her hands and feet, so much so that even the shoes that she was wearing, she had made modifications to and had cut certain parts of them out to make them a little bit wider or to not have as many pressure points in certain areas for her. As we said previously, she had no systemic signs and symptoms outside of the pain and discomfort that she was in. And so I elected to proceed without biopsy because at the time it wasn't going to change my plan of care because we felt pretty confident with our clinical diagnosis upon evaluating her and getting a really good history. She came to me quite informed as a consumer about what some of the causes could be. And so what I wanted to open up the discussion for with her management was, would you have ordered any additional tests at this initial time, given this information that you had? And if so, what would you maybe have ordered?
So, first of all, this poor patient, my goodness, she was needing our help for sure. And then, as far as any kind of additional testing, I agree with you. Biopsy probably wouldn't have helped us in any way, wouldn't have changed what we were going to do. I am glad she did not have any systemic
Mhm.
symptoms, but I would want a fresh set of labs. I don't know if she had someone that she had been seeing and they had done labs recently. I probably would just run a panel anyway. Not that I'm specifically looking for anything, but I don't want to miss anything. And she's probably going to need to be put on some systemic something other than what she's on or in addition to. So I just want to kind of rate her overall health.
Yeah, I think that that's an excellent point. We did end up requesting some of her labs because the her rheumatology team that she also was seeing had her doing monthly blood draws. And she was told that was because she was on weekly Humira. But we were, everything looked good on her labs. But I think that that's a fantastic point. So have you in your clinical practice seen TNF inhibitors such as, Humira or adalimumab lead to these kinds of psoriatic flares before?
So I actually have. I've been practicing quite some time, but I haven't seen it very often. So I know for a fact I've had several patients get a change in morphology that I can remember off the top of my head, specifically with adalimumab. So it is something we need to kind of keep in mind. You definitely want to go down the road of triggers with a patient like this. You said that she had had prednisone in the past. Had she taken it recently? Is this a flare from her coming off prednisone? Or could it be the adalimumab? So certainly something to keep in mind and to consider.
Yeah. Any thoughts on what you might, consider in terms of her current systemic biologic and in terms of, there's multiple treatments for the uveitis, which I'm sure, I became more familiar with it than I had ever been previously. But any
Yes.
considerations with that you would think of with consulting or?
So the problem with the uveitis is there are other treatments, but
Mhm.
it's kind of a catch-22 because most of the data you'll find is like prednisone, which of
Yeah.
course you don't want to give her because you don't want to, her skin to be a mess again when she comes off of it. And then other things like methotrexate and mycophenolate. I mean, there's all kinds of different immunosuppressants. You can go down those roads, but then you have to start worrying about the adverse events and, what kind of problems is she going to have? What's her health look like? But then if she's wearing sunglasses, great point you made. Coming into the office, it either means number one, her uveitis is not under control, or number two, it's so advanced, she's starting to have that photosensitivity. So I'm not sure that there's anything other than adalimumab that really shows great efficacy in those areas. So a lot to think about with this patient.
Yeah, I found her to be quite complex, but I thought it was just such a great learning case because of all the different little nuances here. So I appreciate your feedback on that. Any other treatment modifications that you would make at this time with what you know about her case?
So I probably would go ahead and decrease her dose of adalimumab just for the time being, just to see what we're going to do with her. And also, I think definitely we're going to have to give her some kind of relief. She's in pain. Do we need to add maybe an anti-inflammatory? Do we need to add, definitely are going to have to add something topically for her. It seems like she has a lot of body surface area going on. So we're going to have to be careful with topical steroids, but that sounds like something that she's going to need to start. And we got to try to give her some relief and control as soon as we can before we start making just big decisions on what we need to do.
Excellent point. Yeah. All right. So what came next was, just to your point, as you said, the dose was reduced to biweekly. The care team wasn't really in favor of discussing other treatment options because of the severity of her uveitis. She had pan-uveitis. And so they were really hesitant to add on or make any modifications outside of reducing that dose and giving it a little time to see how she responded. And in all honesty, that made her the most comfortable as well, because as we know, when these patients are so complex, sometimes the baby steps, if you will, are the most important factors, because radically changing things, you know, it's so disruptive, sometimes emotionally and then potentially physically, that you think you're going to do what's in their best interest, and it may or may not backfire. So I thought this was a nice step for her, and she felt comfortable, because the mental part of this was a big part of all of her care as we went along in these serial visits. And we did introduce the clobetasol ointment. She hadn't been on an ointment before. It had been a cream. And so this was completely a game changer for her. And I found that often when people come to me and it does involve like palms and soles, the clobetasol, people are like, oh, it didn't work. And as soon as you ask them what was the vehicle and you explain to them what that is, they're just so impressed when they actually take that home and use it. So we used it on the hot spots on her body and then hands and feet. And it was such a significant improvement in her quality of life. Within 2 weeks, she came in wearing normal shoes. So that was, you know, it warms your heart, you know, that you've made such an impact on somebody. Her trunk was still mildly uncomfortable, but there was so much less overall skin involvement that she was really quite satisfied with where she was at, given her whole clinical picture. So our questions, now that we have this information, is would you do anything to modify this patient's treatment now that she's doing good, but not great? You know, is that enough? If you hear your patient say that and you think, well, I could tweak this, but if you're comfortable and you're content, do we want to?
So great point that you made about, you don't want to disrupt her. If she's on, a pretty high dose of a anti-anxiety, it seems like she's kind
Mhm.
of just very panicked and frustrated and worried anyway. And so we definitely don't want to throw her into a frenzy with that. But, with using the topical steroids, you're totally right. Ointments for sure work really well on hands and feet. And a lot of times, if you can just get that patient's hands and feet to feel better, where they can actually put shoes on and they can function on a daily basis, it does help them a lot. But then you have to think about it. Clobetasol is strong. It's the only thing really that's going to work in an ointment based. And you don't want her to get where she wants to use it all the time. And you certainly don't want to start causing those skin adverse events from her using it all the time. And then, of course, you could throw in some non-steroidals in there to try to keep it under control. You really have to talk to this patient about quality of life.
Mhm.
She's good, she's not great. Me personally, I'm sure you personally, we want the patient to be just as good as possible. I want them to be crystal clear if I can get them that way. But sometimes that's not the patient's goal. So we have to just make her comfortable. I really do feel like that she needs help from a lot of aspects. That she's one that needs a whole entire care team.
Mhm.
Just not dermatology is not going to do it. But she needs a lot of collaboration.
Yeah, and that's exactly where the next question was leading into. You know, in your practice, have you, collaborated on more challenging cases? And then, would you with this case?
Absolutely. I think from the referring dermatology practice, you have to get her entire history of medical history, derm history, what she's been on. Has it worked? Has it not worked? And then we need help. I definitely would say I need help for sure
Yeah.
with this patient. Maybe she needs another rheumatology consult. Has she seen ophthalmology? Maybe they could throw something in there for us. She may not be able to stay on adalimumab high dose. Maybe she can stay on it lower dose. And then she may need combination therapy. But I think we need to get everybody's thoughts going here. And we might even need to try something, hate to say this, but off label. I mean, we do that sometimes, trying to just get this patient's control better.
Yeah. Excellent points. It was actually, we had talked about if it continued to be a struggle with the collaboration locally, that she may do really well in more of a tertiary, like academic center, where teams are used to collaborating and getting together, and that I can be her second line, but she may need a different quarterback if we're unable to achieve some of this. So I think you had excellent.
It's totally excellent point from you too. And I think I do that here in Dallas too. We've got UT Southwestern and Baylor, and boy, if somebody difficult like this comes in, we're like, hey, why don't you head on down to where they know much cooler things than we do?
Absolutely. And it's not because we can't, but I want you to have the best of the best. And to your point, maybe there is something right off label that I'm unaware of, or that, and we're all going to learn from this, and I'm not terping you by any means to say you go to another place. It's just, let's loop them in and let's all work together. I think
absolutely.
That's so important. Oh, that's great. I'm glad you have those resources. All right. So we're a month later. The patient is dealing with some cycling flares, and they're much milder in nature. So we're, kind of attributing that to the decrease of every other week with her biologic. The clobetasol was enough to reduce her discomfort on her acral surfaces. And we did use some topical non-steroidals when we were taking the holidays from the clobetasol, right? To give her the break, what we call pulse therapy. We're going to pulse with the clobetasol, take a break, but I still want you to use something that's going to be anti-inflammatory and hopefully reduce, the frequency and how much you need the clobetasol. So 2 months later, she came in, and, there were tears, and there were tears of relief and appreciation. And then there were just tears from the overwhelming fatigue and frustration of still dealing with it, being frustrated that she didn't have a cure for any of it. She's in her mid 40s and dealing with some pretty significant health issues here. And so, to have someone be so appreciative and thankful, and then so just disheartened by the whole experience and just suffering the fatigue. We always talk about procedure fatigue, and sometimes you forget about visit fatigue, right? And it's visits with us, visit with room, visits to the lab, right? We talked about monthly labs that she was having to have drawn. And so this is a working woman, with a family. And so it really was becoming a lot on her. And, there were certain moments where she was struggling with part of her rheumatology team, and questioning whether or not she should seek a second opinion, because was there something better? And we talked about that tertiary care center, and she remained mild enough to tolerate it, but was that really appropriate? Did she have to tolerate it? Her hands and feet were still limiting her daily functioning by more than about 50% each month. She was only able to go into the office about twice a week. Other than that, she was having to work from home. And so that she found rather isolating as well. And so that's just, to the point of that whole patient, that you're treating and what we're seeing. So when we take her, into consideration, I had to think out of the box a little bit. And as I said, I reached out to my collaborative, Dr. Charlie Camisa, to say, hey, what else should I be thinking here? Behçet's was one thing that popped into our mind, and she had previously been tested for that when I was able to get all of her other notes. But, what do you suspect essentially going on with this person, not only just physically, but also mentally?
Exactly. She definitely needs better control. She definitely needs a large care team to make sure she gets that control. We talked about the consults are going to be the best, but also I think us as providers are going to need to reach out as well, so that we're all on the same page, because it really, I think, mentally gets the patient a little concerned and kind of panics them a little bit when they're seeing all these different providers to try to get her control. Nothing's helping, and no one agrees on anything. And
Mhm.
I have sent patients from dermatology to rheumatology, and I've had them on something, and then the rheumatologist takes them off, puts them on something else, and they come back to me, and I'm like, hold up, I don't want you on that. I want you on this. I'm like, so
Yeah, I
everybody, especially with her, has got to be on the same page. And I think that's super important. Especially, you mentioned here, fear is a driving factor. I think she needs to be super educated. She probably doesn't comprehend everything we're telling her just because of her anxiety when she's in the office. This is when a lot of patient education and handout materials do well. But again, I think whoever she sees, rheumatology, ophthalmology, anybody, we all have to be on the same page so that we're all reassuring her that we're going to take care of her.
That's a great point. I appreciate that. And the next question was a rheumatology consult, and I think we agree that not only that needs to help happen, but we even talked about mental health and trying to do a visit even virtually so that it wouldn't burden her with trying to go out of the house and having to another appointment to schedule. And she was going to give that some thought because that became more of a driving concern, not only with the anxiety, but just do we have some depression going on here? And you really suspect that it is, but to have a patient who feels so comfortable with you. I guess where my next question kind of leads in is when we talk about the fear driving patient behavior, sometimes what we do, we don't really think of, they're like pearls, right? They're just, it's what we do, it's just how you are in clinic. You don't kind of give yourself a pat on the back because it's just who you are and how you practice. Could you speak to at all how you best support your patients when they're kind of paralyzed by fear of change or the consult, or they're scared, to your point, of the side effects from other systemic medications? It's kind of, how do we get them over those hurdles to really get them in a direction where we feel like might best support them?
Yes, absolutely. And I think we know that patients with any type of psoriasis have a very much increased risk of having depression. And I think, consulting them on that, letting them know they're not the only one, like you're not the only patient that is, panicked or depressed or anxious because of your skin, but also letting them know that I always tell them when it comes to a medication, I tell them, I know a lot about these medications. I read a lot about these medications and I know the data inside and out. And I tell them I personally would take this medication if I was in your shoes. And I think a lot of times that gets them to where, oh, okay, well, if you would take it and you know about it, then it's probably not going to be so terrible. But she really, really, I agree with you, needs mental health counseling as well. Great idea with virtual. This, poor lady has been to so many visits and labs and everything else. Let's try to get her virtual if we can. But she, I think, would benefit from that greatly.
Wonderful. Thank you for sharing some of your clinical pearls. And I like that. I would take it too. Kind of gives it like the blessing, right?
Mhm. Absolutely.
Well, thank you. Well, thank you so much for participating, and thank you everyone for watching this program. To receive ANCC credit hours for this activity, please complete the short post-test and evaluation. Keep an eye out for further DNA educational activities in the near future. And thank you so much, Christine. This was such a pleasure.
Yes, thanks for having me. I really enjoyed your case. It was a tough one.
Thanks.
But yeah, thanks for walking through it with me.
It's been great.